Good
Me?
morning, Tree. Good morning, Vitri.
Okay, maybe we should start because it's already 8:30. So I will start with some opening and then we can hear the presentation from Tess. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. And thank you for joining us today. As you already know from the agenda, today we're going to hear a presentation from Dr. Tesfaye Gebremedin on public health insurance and maternal health care utilization in India. This is a part of our current collaboration. So University of Canberra and also Universitas 11 Maret has already collaborated for the past 2 years. Last year, we have Dr. Itis Mita and also Dr. Niranti come to UNS to share their expertise. And this year, we have the honor to have Dr. Tesfaye today going to share his research finding and expertise with all of us today. Before we start with the presentation, I'd like to share a bit of the rundown for today's event. So before we start with the presentation, we're going to have forward from Dr. Tri Mulyaningsi as the head of the Applied Microeconomics Research Group at UNS. And she is also the PI, the principal investigator for the study that currently we are collaborating on. This is a study on stunting, but we have been able to discuss further, and hopefully this collaboration also expand further to maternal and child health, as we are going to have the presentation today as well. And after that, we're going to have the presentation from Dr. Tesfaye. And this is a joint project, joint paper or publication with Dr. Itismita Mohanty and also Dr. Theo Neon Senga. So we're going to hear about maternal health care in India and how public health insurance affect the maternal health care utilization there. And this is something very relevant to Indonesia because until now, we still see high maternal mortality, and with the similarity between Indonesia and India, we can learn from each other from this presentation. And then after that, we will have discussion. Everyone here, you can start if you have question, you can start by typing in chat so that we will be able to read the question at the end of the presentation. And then after that, we will close today's presentation. So without further ado, let's start with the first agenda. Forward from Dr. Tri Mulyaningsi. Dr. Tri, the Zoom is all yours.
Thank you very much, Dr. Fitri, for your kind introduction. So, Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone in Solo or other part of Indonesia, because we also aware that some of our students and colleagues also doing an online learning from not only from Solo but also from other part of Indonesia. Good morning as well for our colleagues from University of Canberra, Dr. Tesfaye, Dr. Itismita, and perhaps we have some more coming in to our session today. So thank you for your interest to join today's webinar. We have some students from Faculty of Economics and Business as well as students from Faculty of Health. So this is the multidisciplinary topics that we're going to listen from Dr. Tess. So we are very fortunate to have Dr. Tesfaye and his colleague from the University of Canberra to share their study. The study has been explained by Dr. Fitri. So the webinar is a regular activities that we have organized since 2020. And today's seminar is the 5th webinar series. And we choose to, for today's seminar, we choosing topic of maternal and child health. So the webinar is presented as part of international research collaboration between UNS and University of Canberra, and its collaboration is funded by UNSP and BP Research Scheme 2021. I would like to introduce researchers from UNS, myself, Tri Mulyaningsi, and we have Dr. Fitri Widyaningsi from Faculty of Health and Dr. Vincent Hadiwiono from Faculty of Economics and Business. We also have 3 partners from University of Canberra. Today, we are very fortunate to have Dr. Tesfaye to share his studies on maternal health. And we also have Dr. Itismita Mohanty and Dr. Riana Miranti. So we hope that you enjoy this webinar. We can learn from Dr. Tes and his study and having a fruitful discussion. So thank you very much. I think I return to Fitri. Mbak Fitri, thank you.
Thank you, Dr. Tri, for the introduction to our research and also the collaboration between University of Canberra and also Universitas 11 Maret. And now we're going to come to our main agenda for today, presentation from research conducted by Dr. Tesfaye, Dr. Itismita, and Dr. Theo. Before we start, I'd like to introduce our speakers for today and also the co-speakers. Dr. Tesfaye Gebremedin is an assistant professor of economics at the Faculty of Business, Government and Law in University of Canberra. Before this appointment, he was also a lecturer in economics at University of Sydney. Dr. Tesfaye's major research interest is in development economics, labor economics, applied microeconomics, economics of education, and health economics. Dr. Tesfaye holds a PhD in economics from University of Sydney, MA in economics from University of Tsukuba from Japan, and BA in economics from Addis Ababa University, Ethiopia. And I also like to introduce the co-speakers, Dr. Itismita Mohanty, who is also joining us today. Good morning or good afternoon, Dr. Itismita. Dr. Itismita Mohanty is a senior research fellow in the Center for Research and Action in Public Health, University of Canberra. And she was also a research fellow at National Center for Social and Economic Modeling. She completed her PhD in economics from University of Sydney, and prior to her current work, she was also associate lecturer in economics at University of Sydney and also Curtin University of Technology, Sydney. And we also welcome here Dr. Theo. Good morning, Dr. Theo. And Dr. Theo is a professor of biostatistics at University of Canberra in the Faculty of Health. And he completed his PhD in mathematics, physics, engineering science, and also Master of Science and PhD in mathematical statistics. He has work experience before by working as postdoctoral research training in biometry at the University of Montreal, Canada. And he works at University of Sherbrooke, and then University of Florida International University, and also University of South Australia prior to joining University of Canberra. So let's start with the presentation. Dr. Tesfaye, the time is all yours.
All right, good morning, everyone. Thank you for coming to our presentation. I understand it's early morning in Indonesia, 8:30 a.m., but it's 11:30 a.m. in Canberra. So thank you for coming. I would like to thank Vitri and Vincent for inviting us to give this presentation in your webinar at Universitas 11 Maret. As Tri and Vitri mentioned, I'm going to give a presentation on the topic public health insurance and maternal health care utilization in India, evidence from 2005-2012 mothers cohort. Vitri has kindly introduced all of us. My name is Tasfaye. I'm a senior lecturer in Faculty of Business, Government and Law here at University of Canberra, and I'm also research associate at the Health Research Institute at the university. My co-authors, Associate Professor Itismita Mohanty and Professor Tioni Onsenga, are also with the Health Research Institute at the University of Canberra. In my presentation today, first I will label the background of the study, followed by a discussion of the research questions that we try to address in the paper. That will be followed by a discussion of the data and methodology used in our analysis in the paper. And then I'll discuss some of our key results, followed by a discussion of some key discussion points. Okay, I was having a bit of a network issue earlier, so I'll just turn off the camera to reduce traffic, if that's okay. All right. Okay, now, as you can gather from the title of our paper is about maternal and child health in India. And there have been significant progress in the maternal health space over the past 2 decades in India. For example, maternal mortality ratio decreased from 370 deaths per 100,000 live births in the year 2000 to 145 deaths per 100,000 live births in 2017, which was quite remarkable. That was over 60% decrease in maternal mortality ratio. Similarly, there was a significant increase in the rate of institutional delivery. Institutional delivery is simply, the proportion of births occurring in health facilities, and that increased from 35% in 2005 to 79% in 2016. As a result of this progress, India attracted widespread praise, and WHO called it groundbreaking success. Now, despite the success in reducing maternal mortality and increasing institutional delivery, India still failed to meet the Millennium Development Targets in these areas, and it remained a significant contributor to global maternal deaths. In fact, India has the second highest number of maternal deaths in the world, second only to Nigeria in sub-Saharan Africa. For example, India accounted for about 12% of global maternal deaths in 2017, which was quite high. But there has been, a renewed commitment to reduce maternal and infant mortality ratios in India. And if the trajectory of the past 2 decades continues, then there is hope that India will be able to meet the new Sustainable Development goal targets by 2030. Now, a significant development in India in the maternal health space was a conditional cash transfer program called Janani Surkasha Yojana, JSY program, which was rolled out in 2005. This program is widely credited for the increase in institutional delivery, which I highlighted in the previous slide. So what is this JSY program? The program was basically designed to address inequality in access to maternal and child health care, and it involved giving pregnant women cash incentives to deliver in institutions. So the idea behind the program was that more women would seek institutional care if, let's say, the financial barriers that prevented them from accessing institutional care were removed or mitigated. The program focused or was implemented rather in high high focus, in 18 high focus and 10 low focus states. High focus states were states with poor economic record and poor maternal and child health outcomes, whereas low focus states were the ones that fared better both economically and in terms of maternal and child health outcomes. So as you can see on the slide, all pregnant women in high focus states were eligible to receive 1,400 rupees upon delivery, upon giving birth, whereas in low focus states, the program focused on poor women belonging to marginalized groups, the scheduled tribes and scheduled castes, and they were eligible to receive 1,700 Indian rupees upon giving birth. The scheduled tribes and scheduled castes are marginalized groups in India. I was checking the exchange rate earlier, and at the current exchange rate, 1,400 rupees, Indian rupees, is equivalent to around 271,000 Indonesian rupiah, and 1,700 Indian rupees is around 330,000 Indonesian rupiah. Of course, this is not adjusted for purchasing power parity. It's just to give you an idea in terms of Indonesian currency. Now, under this JSY program, female community health workers would visit pregnant women in their villages. Okay, so they would do home visits, and they would motivate the women to give birth in hospitals. Not only that, they would facilitate antenatal checkups, immunization of newborn babies, and postnatal visits. So, you'd find, and as a result of, these initiatives, many believe, institutional births increased as a result of that. So you'd find many studies in the literature who evaluate, the success of JSY program, crediting this program for the increase in MCH, maternal child and healthcare service, increase in MCH utilization. But there is also evidence, pointing out that, the disparity, the inequality in institutional births has persisted, and that maternal and child health care utilization continues to remain low. And this is especially true among the poor. So, you might ask why many pregnant women are not accessing maternal health care services despite the availability of this program, JSY. Well, studies have shown there are significant out-of-pocket expenditures related to maternal care, and the money obtained under the JSY program is not enough to cover it. So we're talking about expenses on food, expenses on transport to the hospital or from the hospital back to home. We're talking about foregone income of husband, as the husband has to, let's say, accompany his wife to the hospital and potentially stay with her for, let's say, a few days. So there is also, opportunity cost in terms of income foregone by the husband. So, these significant out-of-pocket expenses mean that the JSY program may not reduce the financial burden on poor pregnant women. And the wider literature cites high cost as a major deterrent to service utilization among the poor. Now, there is also a wide literature looking at how out-of-pocket payments on healthcare affects, the welfare of poor households. And the consensus is that, such out-of-pocket expenses could prove to be catastrophic in the sense that, poor households could be plunged into deeper poverty as a result of such expenses. So to protect poor Indian households from financial risks due to hospitalization, the Indian government launched this public health insurance scheme, RSBY, Rashtriya Swasthya Bima Yojana, in 2008. And it is this public health insurance scheme that is of particular interest to us in this paper. So what kind of public health scheme was this RSBY? Well, it covers only poor households. and it covers, secondary inpatient care at community health centers, district hospitals, and medical colleges. And families could receive up to 30,000 rupees per annum for hospitalization under this scheme. So 30,000 rupees would be equivalent to, I believe, 5,800,000 Indonesian rupiah. And out of the 65 million families who had been targeted for coverage, by 2016, 41 million had enrolled in this program. So that's about 63-64% coverage rate. The first research question we try to answer is, has health insurance been a significant factor in increasing women's utilization of MCH services? So we are comparing 2005 and 2012 using Indian Human Development Survey, as I will discuss shortly. Now, in 2005, we only had private health insurance in India because that was before the introduction of the publicly funded health insurance scheme, RSPY, which was rolled out in 2008, as I mentioned in the previous slide. Whereas in 2012, we had both private health insurance and the public insurance scheme, RSPY. So how would health insurance lead to increased utilization of MCH services, maternal and child healthcare services? Well, if health insurance reduces household overall out-of-pocket expenditure on healthcare, which of course was the goal of the government, Indian government, introducing RSBY in the first place. That was the goal. If it reduces overall out-of-pocket expenditure on healthcare, then households would make some savings, which could then be diverted to cover expenses related to maternal and child healthcare. Another channel through which the insurance may increase utilization of services is through the maternity benefits it covers. RSVI, for example, allocates a small sum for maternity benefits. It covers all expenses related to delivery at the hospital, including transportation charges. These maternity benefits covered by the insurance may encourage more women to give birth in institutions. Now, this question of how the public health insurance scheme RSBY affects MCH service utilization has not been investigated in the literature. Now, most studies on RSBY, they looked at the effect of the scheme on out-of-pocket expenditure of households. So this issue of how it has affected MCH service utilization has not been researched in the literature. Now, another question we try to answer is how the public insurance scheme RSBY compares against private health insurance in terms of its effect on utilization of MCH services. Now, as I noted in the previous slide, the 2012 data captures both private and public insurance, whereas the 2005 data captures only private health insurance. So we try to see how effective the publicly funded insurance has been compared to private health insurance. Now, another area of research interest to Tismita and me particularly has been, this issue of women's empowerment. And we try to investigate the relationship between maternal and child healthcare utilization and empowerment of women. So that's another thing that we try to address in the paper. I will explain shortly what kind of variables we used to measure empowerment of women in our study. Okay, we're using the 2005 and 2011-12 survey rounds of the Indian Human Development Survey, IHDS. IHDS is a nationally representative survey covering over 41,000 households in 2005 and over 42,000 households in 2011-12. IHDS collected information on a range of topics, including household and family structure, consumption and standard of living, social and cultural capital, income, education, employment, and so forth. Now, this data set provides a unique opportunity to study how maternal and child health care utilization has changed over time due to its panel component. Okay, so there were a panel of 40,018 households surveyed both in 2005 and 2011-12 rounds. And we were able to identify 4,289 mothers who had given birth in both periods, allowing us to compare, change in maternal and healthcare service utilization over time. Okay. Okay. Now, how do we measure maternal and child healthcare service utilization in our paper? The first indicator we used to measure MCH service utilization was whether the mother had delivered at an institution. Okay, institutional delivery. So we defined institutional delivery as delivery at government hospital, clinic, or private nursing home. So if the mother gave birth at home, that was not institutional delivery. The second indicator of MCH service utilization we used was the number of antenatal checkups the mother had received during her pregnancy. So obviously, the aim of antenatal checkups is to identify and manage any obstetric complication, and it also presents with the opportunity to promote healthy practices. The WHO guidelines on maternal and neonatal care suggested that pregnant women should receive at least 4 antenatal care visits prior to delivery. This guideline has been upgraded more recently. I think it's been upgraded to 8 antenatal visits, but we considered in our study 4 to be the minimum number of antenatal visits because that coincided with WHO advice during our period of analysis. Okay. The third indicator we used was whether the mother had postnatal checkups for herself and for her child. And postnatal check involves systematic review of the health of the mother and the baby, and obviously provision of appropriate advice to the mother. And having had a postnatal checkup completed by, let's say, a doctor or health professional was considered as an appropriate indicator of MCH service utilization in our study. Now, we created an outcome variable that combined all these 3 indicators that I discussed in the previous slide. We combined them all because improving maternal and child health outcomes requires not only that women deliver in institutions, but that they also receive appropriate antenatal and postnatal care. So our outcome variable is a categorical variable, which is coded 0 if the mother didn't meet any of the 3 indicators that I discussed. So if it is 0, it means she did not deliver at an institution, she didn't have 4 or more antenatal visits, she didn't have any postnatal check. It is 1 if the mother met the best outcome in only one of these 3 indicators. So in this case, maybe she delivered at an institution, but not or she had less than 4 antenatal checkups, or didn't have any postnatal check, or maybe she had 4 or more antenatal visits but did not deliver at an institution, or did not have any postnatal check. It is 2 if the mother met the best outcome in 2 of the indicators, and it is 3 if the mother met the best outcome in all 3 indicators, meaning she delivered at an institution, she had 4 or more antenatal check, and she had postnatal check. That would be 3. Okay, so that's our outcome measure. Now, our main exposure variable was the household health insurance coverage status. So this, assesses whether the household had benefited from health insurance. Now, as I indicated earlier, this variable captures only private insurance in 2005, but both private and public health insurance in 2012. Our study also controlled for a range of potentially potential confounding variables, which were believed to affect women's utilization of MCH services in the wider literature. We controlled for individual, maternal variables such as, mother's age and mother's educational attainment. We also controlled for, household level variables, including its household size, number of children. Household economic status was controlled for using quintile of household consumption per capita. Below poverty line, BPL status identifies households who hold BPL card. These are poor households falling below the poverty line, and the BPL card entitles them to certain benefits. For example, they may receive 10 kilogram to 20 kilogram of, let's say, food grains per household per month at, let's say, 50% of economic cost. So, holding a BPL card entitles them to certain benefits. We also control for women empowerment variables. We have 3 summary variables that capture women empowerment: mother's bargaining power, mother's autonomy, and restriction on mother's movement. These 3 summary variables were derived after applying principal component analysis on 10 indicators of women's empowerment that we had identified in the data. For example, variables that loaded onto mother's bargaining power were, questions relating to whether the mother was involved in decisions on what to cook, whether the mother was involved in decisions on how many children to have, whether the mother was involved in decisions what to do when children fell sick, whether the mother was involved in decisions, whom children should marry, and whether she was involved in decisions, to buy expensive items. So these were the items that loaded on mother's bargaining power in our principal component analysis. Variables that loaded onto mother's autonomy related to whether the mother could go alone to a health center, whether she could go alone to visit a friend, whether she went out with the husband or children to a cinema or restaurant. So those were the variables that loaded on, mother's autonomy. And the variables that loaded onto mother's restriction restriction on mother's movement were questions relating to whether the mother needed permission, whether she needed permission to visit a health center or whether she needed permission to visit a friend. One variable, whether mother had her name on property document, on the rental or property documents, didn't load onto these 3 variables, 3 factors. So we included it as a separate regressor in our regressions. Okay. Okay. The model we used to analyze the change in MCH service utilization over time is the multi-level mixed effects ordered logistic regression. Now, why multi-level? It was to take into account, the nesting in our data due to the hierarchical structure of the data. For example, surveyed women in our data are nested within households, and households are nested within communities, and communities are nested within districts. Now, this means you would expect pregnant women living in the same communities to be subjected to the same factors that would affect their MCH service utilization compared to women living in other communities. Similarly, pregnant women living in the same districts would have similar healthcare infrastructures, and they would be subjected to similar policies than women living in other districts. Standard single-level regressions would treat these women in the same communities or district as independent, which they are not. So, a multi-level model takes care of this nesting in the data. We used ordered logistic regression because our response variable, the outcome variable for MCH service utilization, which I discussed earlier, is ordered, ranging from 0 to 3, as I discussed, 0 representing mother's who didn't meet the best outcome in all 3 indicators, 3 for a mother who made the best outcome for all 3 indicators. Now, in our multi-level modeling, we consider 4 levels of hierarchy: district, community, mother, and within the same mother across the 2 survey periods, 2005 and 2012. So we have included, random effects at the district, community, and mother levels. This means we are allowing variation in maternal and child healthcare service utilization across districts, communities, mothers, and between the same mother across the two survey periods. And we had carried out likelihood ratio tests comparing this 4-level model against 3-level and 2-level models. And this 4-level model is a better fit for our data. Let's look at our regression results. Again, keep in mind all our regressions include random effects at the district, community, and mother levels. Now we introduced our variables stepwise. In our tables, we report the odds ratio, and the 19% confidence interval is in brackets. Now our first model controls for year of survey or survey wave. Okay, and we can see that maternal child healthcare service utilization levels had significantly increased over the 2 survey periods. So in terms of magnitude, you can see the odds of attaining a higher MCH utilization level increased by almost 4-fold over the period of study between 2005 and 2012. And all statistics from India show that MCH service utilization had increased over that survey period. So this is also something confirmed by overall statistics in India. Our second model controlled for survey wave, which were controlled for in the first model, and whether the household had benefited from health insurance schemes. Now, the odds associated to both year of survey and health insurance schemes were statistically significant, as you can see. The odds of attaining higher MCH service utilization was 49% higher for mothers with health insurance compared to mothers who didn't have health insurance. Now, at this stage, we're talking about health insurance in general. Okay, so this odds ratio that you see here includes the effect of both private and public health insurance. Okay, now let's move on to model 3. Now, this model included an interaction term between survey wave and health insurance, okay, in addition to the variables we controlled for in the earlier models. Now, including this interaction term enables us to capture the differential due to having health insurance in 2012 compared to 2005. So, it allows us to basically compare the impact of health insurance on MCH service utilization in 2012, which was after, RSBY had been introduced, with 2005, which was before RSBY had been introduced. Now, interestingly, the effect of health insurance on MCH service utilization in 2012, as you can see, is weaker. It's like 0.42 times the odds in 2005. Now, if you were to compare households with insurance and those without insurance in 2005, those with insurance were 3 times more likely to attain higher MCH service utilization scores. 3 times. This is for 2005, okay? Comparing those who had insurance with those who didn't have insurance. If you make the same comparison in 2012, however, you would notice those with insurance were just 1.3 times more likely to attain MCH service utilization than those without insurance. So this combined the log of odds, these 2 log of odds. That's how you'd calculate it. You'd combine these 2 log of odds and convert it into odds ratio. So in 2005, those who had insurance were 3 times more likely to attain higher MCH service utilization, whereas in 2012, those who had insurance were only 1.3 times more likely to attain higher MCH service utilization. So this means, the effect of health insurance on MCH service utilization weakened after the publicly funded health insurance became available. Okay, so model 4 controlled for women empowerment variables. Here, women empowerment variables. In addition to the variables were controlled in model 3. Now, the variables we looked at in the earlier models are still statistically significant. Year of survey, health insurance, the interaction between WAVE and health insurance are still statistically significant. Women empowerment variables are also all significant in this model. You can see mother's bargaining power, mother's autonomy, restriction on mother's movement, whether the wife or the mother had her name on rental or document property are all statistically significant. Mother's bargaining power was only significant at the 10% level of significance. You can see that mother's bargaining power, mother's autonomy, and the mother having name on the rental or property document, increased the odds of, the mother accessing MCH services, whereas, the mom facing restriction on her movement reduced the odds of the mom accessing, MCH services. The next model, let's move on to the next model, model 5. This included interaction term between year of survey and women's empowerment variables. Okay, so this will allow us to see how the effect of women's empowerment on MCH service utilization had changed over time. Now, all other variables that we considered in earlier models remain statistically significant. So in this table, I only present the women empowerment variables and their interaction with survey WAVE. Now, the interaction between mother's restriction on movement and WAVE and mother's autonomy and WAVE were statistically significant, whereas the other interaction between WAVE and mother's bargaining power and between WAVE and whether the mother has name on rental property, they are not statistically significant. So these two were the ones that were significant. Now, restriction on movement had a stronger effect. So if you look at this one, this shows us, the restriction on movement had a stronger effect in 2012 compared to 2005. Whereas interestingly, the effect of mother's autonomy in increasing maternal child health care utilization was stronger in 2005 than in 2012. Okay, so that's what our results show us. Going to our most comprehensive model, in the most comprehensive model, we had included host of confounders, which I discussed earlier. The model also retained all other variables that we discussed that we had included in the earlier models. I had broken it into 3 here. Now, the year of survey, you can see here, it remained statistically significant, but health insurance and its interaction with WAVE were no longer statistically significant. So when we included, mother level and household level confounders, health insurance lost its statistical significance. It was no longer statistically significant. Among the maternal variables, you can see mother's age and mother's education were both statistically significant. The odds of accessing, MCH services increases with mother's age and mother's education. But you can see it decreased with the total number of children the mother had. Household consumption per capita was also quite significant, with mothers coming from higher quintiles more likely to access MCH services. Another interesting result we found was, those households who were holding BPL cards. I explained BPL cards earlier. BPL cards, they were more likely to access MCH services than households who didn't hold BPL cards. Among the autonomy, rather mother's empowerment indicators, mother's autonomy and whether the mom had her name on property document or rental document remained statistically significant, while mother's bargaining power and restriction on movement were no longer statistically significant in our comprehensive model. Okay, now all our models show that pregnant mothers were more likely to access MCH services in 2012 than 2005. Now, as I mentioned, this is consistent with the various government initiatives and overall concerted efforts to increase pregnant women's access to quality MCH services in India since 2005. Some argue, the cash transfer under JSY had incentivized more women to deliver in institutions, but the role of cash transfers in motivating women to access MCH services may not have been significant, since more and more studies are showing the amount of transfer is not enough to cover out-of-pocket expenses. Another possible explanation to this increased MCH access is attitudinal change among women in society over time. Attitudinal change. So researchers have noted, there is this socio-cultural preference for home-based births in India. There is this prevalent view that childbirth is a natural occurrence that doesn't require professional assistance. But there is evidence that these female community health workers, SHS, which I mentioned earlier, who visit pregnant women in their homes and provide them counseling, there is evidence that these female community health workers have helped to change the society's attitude towards maternity care. Okay, so that would also, explain the increase in MCH service access, attitudinal change among women in the society. As we noticed in our tables, models 2 to 5 also showed that households with insurance were more likely to access MCH services than those without insurance. Health insurance is expected to reduce burden of costs associated with healthcare, so it would encourage more mothers to access MCH services. However, our results indicated that the publicly funded insurance scheme did not have as a strong impact on MCH utilization as private insurance. Now, this could be because RSPI is not preventing, rather is not providing poor Indian families with any significant protection from financial risks. Studies have found, studies have found families are still incurring significant out-of-pocket expenses, even for inpatient hospital care, which RSPI was meant to cover. And there is also evidence that, financial burden on disadvantaged households, disadvantaged groups such as, the scheduled castes and scheduled tribes had increased, in spite of the public insurance being available. So these reasons may explain why RSPI has not had any significant impact in increasing MCH service access. The health insurance variable was no longer statistically significant when other household and mother level confounders were added into our model. And this implies that these other predictors, mother's age, education, household wealth quintile, were more significant in determining access to MCH services than insurance in India, health insurance in India. Our finding that more educational attainment leads to more utilization of MCH service is supported by other studies in the literature. Education increases mothers' awareness of health-related information, which makes them more predisposed to access MCH services. Education is also critical in imparting the feelings of self-worth and self-guidance, which are critical in bringing the change in health-related behavior. The mother's utilization of MCH service decreased from our results. We saw it decreased with total children born, not with household size. Household size was not significant in our regressions. MCH service utilization decreased with total children born to the mother. Now, this means more children means there would be more demand for the mother's time, more demand for her time at home, adversely affecting her utilization of MCH services. So the lack of time due to, let's say, household chores and other responsibilities has been identified in the broader literature as one barrier to MCH service utilization in the Indian context. Household wealth is another significant factor with the odds of MCH service utilization increasing as we move from the lowest to highest quintiles of consumption per capita. So, mothers from lower consumption quintiles, they may face financial difficulties when trying to access MCH services because, as I mentioned, there are many direct and indirect costs involved. We're talking about cost of medicine, cost of transportation, foregone salary or foregone income of the husband. In the Indian case, also bribery, bribery at the hospital and health centers to get the service that you need, bribery. Zodpi and Faruqi, for example, they noted around 50 million households slip into poverty each year due to out-of-pocket health expenditures. And this is for India, okay? So this is still happening, despite the availability of the publicly funded health insurance scheme, RSBY. Now, among variables that capture empowerment of variables, maternal autonomy was associated with more utilization of MCH services. This variable reflects mother's self-determination and power to make her own decisions and choices. So a mother with more autonomy is able to get out of the house by herself and is more likely to come across, let's say, valuable information and advice on various aspects of maternal and child health, and should be able also to visit health centers for necessary health checks by herself. Okay. Mother having name on the rental, there is a feedback coming. Is it Fitri? Okay, thank you. Mother having name on the rental or ownership document of the residential property is also associated with more MCH service utilization. This variable obviously captures economic empowerment, and you'd expect economically empowered women to make decisions on healthcare and other aspects of life that would benefit them and also their children. So I will stop my presentation here and open the floor for discussion. Thank you for listening.
Thank you very much, Dr. Tespe, for the very interesting presentation. And we learned so much from this presentation by knowing about the program that has been implemented by the Indian government for improvement to improve maternal health. And also, it's really great that India already reduced the maternal mortality ratio, because Indonesia is still pretty high. We're still at over 300 for MMR, so we can definitely learn from India and also the many programs that you mentioned. And there are some similarity with the program that we also conduct here, actually. So, like, for example, you mentioned the conditional cash transfer program. We also have a similar program here. And then the public health insurance, we have the health insurance for the poor, and also specific insurance for maternal periods. So it covers pregnancy and delivery. So we can probably learn more about that later through the discussion section. We have
interesting.
We have several questions from the audience. First one is from Tri. Tri wants to ask about, there are two questions. The first is, please explain about the public insurance in India. So whether it's a government who's going to pay for the premium, or whether other entities paying for the premium. And number two is, she's wondering about the proportion of women living in the same household, because you mentioned there are about 40,000 households, and then more than 4,000 mothers who give birth in the first and the second survey period. So are they, for example, mother and daughter living in the same household, or the same mothers who actually give birth in the first and also the second period?
Okay, if I maybe answer from the last question. So we captured, the same mother who had given birth. Okay, so yeah, I mean, because of this extended family system in India, you're right. Mothers and daughters live in the same household, but our data captured, the same moms who had given birth between 2000 and 2005 and between 2007 and 2012. Okay. So there are a panel of 4,209 mothers who are given birth across the two time periods. Okay, so I mean we didn't capture, let's say, a mother and her daughter giving birth. That's not captured in our data. Okay. With respect to the first question, the public health insurance in India, it is publicly funded. So the payment it comes from the government, basically. Okay. Itismita might want to add more comments. I don't know. Itismita, do you want to add anything more?
Hi, can you hear me?
Yes, we can hear you.
Hi, thank you, Tesfa, for very good detailed presentation. Thank you, Bitri and Tree. Yes, in the public health insurance, RSBY, Rashtriya Swasthya Bima Yojana, is publicly funded. It's not like the government pays premium from household to household, but it is like a government maintains a certain threshold, and if the income of the household falls below that threshold, then it increases or decreases the limit. So RSBY basically, when it provides certain amount of money allocated for the household basis, like Tespa said, maybe during that period it was 30,000, but it has increased significantly in the present days. Like there are Ayushman Bharat Yojana replacing RSBY.
We lost you.
Yeah, we lost you. Itismita. Hello. Okay, so
okay, that's fine.
Yeah.
Can we move to the next question? Is that okay?
Yeah. So I think we already covered the questions from Tri, and the next question is actually based on the presentation, as you mentioned, with all the different models, you come up with conclusion that health insurance only specifically is actually not really significant, if I'm not mistaken. So have you tried to do, like, for example, analyze whether probably for certain people or characteristic, or for example, for poor people, this is actually significant, or maybe stratified also by the outcome. So for example, it might be not significant for antenatal care, but maybe significant for delivery or institutional delivery. Is it something that you investigated, or do you think that's also something that might happen in this condition?
Okay, it's an interesting result. So as I discussed, our outcome measure, it combined institutional delivery, antenatal check, and postnatal check. Okay, and that's because this continuum of care is very, very important for women. It's not just institutional delivery, but continuum of care from, let's say, antenatal checks to institutional delivery, going on to postnatal check. Okay, so the question is very interesting because we didn't check separately if insurance was let's say significant, if we considered antenatal separately or institutional delivery separately. Okay, so we didn't check, but you mentioned whether it was significant for poor people. It is mostly, mainly poor people who are recipients of these insurance schemes. It's poor people. I mean, RSPY, the target are the poor people. JSY are also the target are poor people. Okay, and the reason that it's not significant, or it didn't come up significant, and other studies are also arriving at the same conclusion, is because, as I said, there are significant out-of-pocket expenditures which the insurance is not covering. Okay, as I said, even foregone income of the husband, who has to stay with the husband, with his wife, while she's getting this treatment or delivering and so forth, transportation costs and so forth. Okay, so they are not covering these out-of-pocket expenditures, and that's why, despite the availability of this insurance, still women there is, women are not benefiting really. Okay. We were planning to look at only antenatal study. That was sort of a second project that we were thinking about. But as you may have noticed, 2012, the data is a bit dated. But unfortunately, that was the only data set that allowed us to investigate, the same mother across time. There is DHS, which is available. The latest DHS for India is, I think, was done 2016, 2017. It's just been released. But as you know, DHS, it's not panel, it's not longitudinal. Okay, so that's one reason why we're interested in this data set. It is Mita, I want to add something.
Can you hear me now?
Yes.
We can hear you now.
Yes. Also, Tess, I think we have control for the BPL and the wealth quintiles in our model.
Interesting
right?
point. Interesting
Yes.
point. You're right.
So,
You're right.
So that has been taken care of. After controlling for that the results we see that the public health insurance is not actually influencing maternal and child health for the same mother over time. So we have actually control for BPL, the below poverty line, and also wealth quintiles in the model. So,
wealth quintile is there. You're right.
Okay. Thank you. We have some more questions. Actually, we have several of them. The next question is from Josephine. So she read from the news that there's a maternal mortality because they cannot get access to institutional delivery, and this is because, and this is maybe like a clarification whether India has policy to restrict the number of children, and also this one restrict the number of children that can be reimbursed by the social health insurance. Maybe is it going to be Tespe, or maybe it is Mita? You can explain about the policy that she's questioning.
Well, in terms of, okay, we will both try to answer the question. In terms of getting to hospitals for institutional delivery and so forth, this JSY program, it also gave, some money for transportation, and the female community health workers that I just talked about, they also arranged transportation for these mothers. Okay. Now, whether they arrange this for every mother, obviously, is another question. Okay. But it is part of the program. They are meant to arrange transportation to health facilities and so forth. Yeah, it is Mita. You want to add something on that?
Yeah, in terms of restricting policies for number of children, no, India doesn't restrict strictly for number of children, but it has some promotional scheme over the years for population control. But that was like if you have two children, then there are certain promotional but India doesn't have any restrictive policies like they cannot have children more than one or two that kind.
So it's more of a recommendation, right? It is Mita, so not really restricting and then limiting access or to, for example.
Not limiting access, it was rewarding things, certain rewarding things. If it is like not more than, if people have not more than, like if they have two children, then there are certain rewarding policies, but there was no restrictive thing. But those things has changed over time also. They are not restricting, like even those rewarding policies are even now less and less.
Okay, thank you. I think that's pretty clear for Josephine. So it's more like recommendation and reward, like you mentioned. So not really restricting the number of.
No. Yes. It is never restricting policies. And in terms of why poor people are not being able to access public insurance, definitely there are some gaps. Either the program is really not reaching the people, or socio-culturally there are gaps. People are not finding it easier to access the health facilities, even if the public health insurance is there. Right. And just the way Tespa shared, also the other opportunity cost, if they have more children at home, the mother's time is very important considered at home than going and delivering in hospitals. Similarly, the husband, so there are so many other factors that it needs to be considered. And I am a true believer in women empowerment. And I believe you see over the time that it's even if the public health insurance did not work, maternal autonomy and bargaining power did work. So that is quite a change in the society over 2005 and 2012. If we see that now, I think we can see more improvement. So maybe government policies through the women empowerment would be more helpful than availing resources at a public insurance level at a certain limit. That will be helpful. That's what I believe.
And another interesting aspect of JSY, probably, which I didn't mention, was that for those women who decide to deliver at home, if it is attended by a professional, probably a midwife or a nurse, there is some small sum that is given to them under the JSY program. I think, if I remember off the top of my head, 500 rupees, which isn't much actually. So if they decide to deliver at home but attended by a professional, they will get some money.
Yeah, so the program is actually not only institutional delivery, but also for skilled birth attendants that can be
exactly
right. Okay, so that's, yeah, because as it is Vita mentioned, every family, they have their own challenges, and with all the right, so doesn't, yeah, it's maybe for some family it's harder to have institutional delivery. This is actually relates to the your explanation before. There's a question from me, Kadet. So it's particularly for the poor family, and Tess, in the presentation you mentioned that awareness is something that is important for women to access the maternal health care, and it is Mita also you mentioned about that, whether that some people have access but they did not access or utilize the available resources. So are there any steps taken from the government to increase awareness of maternal health, and maybe because he highlight the poor family, are there specific program for this in the poor family?
So, I mean, as I said, a very significant development with the JSY program is that, villages, society's awareness has been increasing. Okay, so these female community health workers, they don't just visit the woman and educate her about, the steps she should take regarding pregnancy, but they educate the whole community, the whole village. Okay, so in this sense, the awareness of the society has been increasing, and that's why we said the increase in maternal child health utilization we observe over time is mainly due to this attitudinal change. Okay, so yes, there is this educating not just the pregnant women, also the whole society, that's being done under the JSY program. If Tismita is aware of other programs, she might add.
Yes, Bitriyama, like along with what Tespa said, also there are very, very strong campaignings going on in India. And one of my students just finished a thesis, like he was doing with Theo and me. He did on the women's self-help groups. So those things are very strongly promoted in India for women's self-help groups. And that was like at a microfinance, like economic level, where it helped women, marginalized women who were in that self-help groups, financial help, and also over that they layered up with health education for maternal and child health. So we had an evaluation, like we have specific data from a state in India, Uttar Pradesh, the biggest state in India, and we saw that like over the period of from 2004 to 5 and 2017-18 data, that it has improved. The self-help groups have actually helped women to access maternal and child health and improve maternal and child health. And it is not only targeting the like the line like prenatal care, institutional delivery, and postnatal care. In those cases, they are actually Danis, my student, actually saw how the knowledge transfer is happening. Is it actually improving the knowledge of danger signs for the complicated deliveries, for obstetric complications? So those things are happening. But as you know, like Indonesia, India is very big, and it has so many states, and it is culturally very variant. So it will take, there is hope, but it will take time. Thank you.
Yeah, thank you. That's very interesting. Yep. To just to share or to compare, like I was interested when Tesway mentioned about the village how we improve awareness of the village. And in Indonesia, we also have similar program. We have the Alert Village program that might be similar to what you mentioned. So the village actually, we improve not only the woman, but also the community knowledge about the maternal health. And whenever there's a woman who is pregnant in a village, then the whole village supposed to have, for example, where the mother is going to deliver, who's going to provide transportation, because as you mentioned, when a woman deliver or when a woman is pregnant, it's not only about the healthcare, but also the support system of how the woman can access the healthcare. So very interesting sharing session that we also see similar program in Indonesia. And also what you mentioned, it is Mita, about the women's self-help group. And I think, Tess, in the beginning, you also mentioned about community health workers doing antenatal care and also immunization. And we have Posyandu in Indonesia, which is also similar. So there are some community healthcare workers, and then they're going to the community, and they have like monthly check for the woman as well as for the children. So yeah, we have several programs that maybe best practices that can be shared to other country as well with similar condition. We still have several questions. This is very interesting talk, so be patient that there are so many questions. So this is a question from Farah from UNS, and maybe it's a bit we're going a bit further from the talk, because then we talk about how the pandemic changed the maternal health condition. And I think it's also related to previous question by Tri. So the first question is, how does India cope with the current surge of healthcare demand and due to the pandemic, and how does it affect maternal health? Especially, do you also, for example, estimate or see increase in delivery due to the pandemic, and how the maternal health care utilization changed during the pandemic? Please share your insights, thoughts. Yeah.
Very, very interesting topic. I think it is Mita probably would be better placed to answer these questions than me. But with respect to the effect of the pandemic, we actually had this conversation, and we were wondering, whether there is a data available to capture that. And unfortunately, we couldn't find the data. So if a data becomes available, I can assure you we'll jump on it and we'll be looking at the effect of the pandemic on MCH utilization. With respect to how it's affecting MCH utilization, maybe Tismita can comment.
No, I don't have, sorry, Tess. I don't have any additional comment over you. As Tess said, that is our next area of interest, because we were discussing it lately. The next paper will focus on this area, but the point is we don't have any data. And again, India is vast, and getting panel data sets on India is very difficult. Like 2012 is the latest that we can get on India in terms of panel. And recently, like with the COVID, it's chaotic in India. Definitely, we are now moving into looking into the impact of COVID, long COVID. Definitely, that would be impact on maternal and child health. That's what we think, but we don't have any more information to tell you how it is affecting people's behavior and access and utilization exactly.
Okay, thank you. Thank you very much. Yeah, this is something very novel, like the name of the virus, very novel. So yeah, for sure. I hope that there will be data available. A similar thing in Indonesia as well, because data is, the latest data that we have is in 2017, and that's way before the pandemic and until now. And doing the data collection during the pandemic itself must be a challenge. So as Smita mentioned, that might also be, we still need to wait to actually assess quantifically about the effect of pandemic on maternal health care. Okay, so there's another questions from Ani, but I think this is a question that we discussed before. So let's move on to the next questions. Yeah, like, and this is also interesting because as you mentioned, health costs and out-of-pocket expenditure is still something that is very prevalent. And as it is Mita mentioned, it might program that wants to improve healthcare might not only focus on like conditional cash transfer or public insurance, but also other we can call it more sensitive programs. We have sensitive and specific programs, so it's not really addressing maternal health care, but it's a wider scale, a more global program that can address different areas. So, like for example, when we talk about stunting, we have the WAS program intervention, and that influence stunting. So, in India, is it something that going on as well right now? So, for example, the government move or allocate resources not only to specific maternal health care program, but to more general program or other program that might be able to impact maternal health care.
Tess, you want me to answer?
Yeah, you can go ahead.
Bitri, there are a lot of programs running at the moment. There are a lot of welfare programs, and at the state level, different states cover differently. So it's not only maternal health targeted, it's welfare program like BPL that is mentioned, like those who hold households, those who hold a below poverty line card, they actually receive free ration on a monthly basis, and they like that supports like for the food insecurity, to target food insecurity, to target employment, and to target other areas. So there are many programs, and it is difficult to capture like we can only capture some centralized program because there are 30 states, and each state is different and their policies are different. So as I said, there are many other programs going on recently. Yes,
okay, thank you. Yeah. Thank you very much. So based on all of these findings, there are several programs, and I'm sure there are so many programs that actually conducted together or simultaneously, and hopefully this can also improve maternal health care, although it's not specific to maternal and child health care. So thank you, Tess. It is Mita, and I think Theo is also answering questions from the chat.
Oh, is he?
Yes, he is.
Thank you for answering directly to chat. And I think we almost come to the end of the today's agenda. We have several questions that has been answered, and I think some similar question and maybe additional questions that can be asked maybe later. And for today, before we close this webinar, I'd like to ask Tess, if it's Mita or Theo, if you want to have closing statement on the subject. So please, Tess, if it's
Well,
Mita,
we can give the honor to Theo maybe.
Oh, yeah,
Theo, thank you. If you
we can highlight you then. So Theo, please.
Well, I had decided to let the young people talk and express the ideas. So that's why I kept silence. So, so I was expecting that Tesfai and Itismita would actually have that honor of leading the future and giving us some of the next topics we would be working on. Obviously, the interesting thing would be to do something similar in Indonesia and be able to have comparative studies. So that's one thing. The other topic you mentioned, which will probably take more time, is the impact of COVID and all the adjustment and kind of chaotic situations we are in. It's not India only or Indonesia. It's in all countries. The only difference is that the Western countries, or let's say Australia, they are just confining us in homes and so on. But again, there is all the aspect of the impact of mental health and well-being, which unfortunately we will know later when we have data. So yes, there are so many things we can look into it. But I guess the next thing is really to look into what do we have as available data, and what programs we can actually aim to in terms of not only studies and analysis publications, but also funding is if possible. So yeah, in brief, that's what I can say.
Okay, thank you, Theo, and thank you also for joining and also answering questions and also the closing statement. As you mentioned, hopefully this will be well, it's not a start because we already start collaboration, but hopefully we can continue to collaborate. As Theo mentioned, Teswe and also Itismita, there are several other data sets that are available, and we can make comparison India and Indonesia, because well, India is number 2 for maternal mortality. Indonesia is number 5, so we're not that far behind. And hopefully we can do something. And with the similarity between the two countries, I think this is, as Theo mentioned, this is something very important to do. And with the current pandemic, we still need to wait for the data that are available. But as you mentioned, yes, there must be effect, because this is very profound, and the increase and the surge in healthcare demand is very profound, and it might affect other programs, including maternal healthcare. And for today, I'd like to conclude today's webinar before we close. And as the presenters have kindly share, there are a lot of different programs to actually improve maternal health care utilization and maternal health in general. And we have to maybe start to think more about what kind of program that actually needed. Maybe it's not only the program focusing only for maternal health, but more general program like the finding of the study that the program to improve women empowerment is something very useful. And although it's not something that you focusing on with the public, showed in your presentation that the woman empowerment is actually something that is very important. And because I think most of here are women, so attendance. So we can start from ourselves, right? It is Mita and Tess and also Theo. So this is something that we can start from ourselves, from our community. I think most of the women here are empowered. So let's start to share those ideas, those proposals, and start small, but start from now with our surroundings. And thank you, Teswe, Itismita, and Theo for the great presentation and also sharing. We learned so much from today's meeting. And before we close, I forgot.
I just want to add a few words, Bitri. Thank you. Thank you. Thank you very much for this presentation, allowing us to present, and very active presentation. Well, staying in Australia, we hardly get an opportunity to present to 100 participants. So it is really very encouraging for us. That's why I will agree. Thanks for all your interest. And yes, women empowerment will be able to help us with improving the maternal and child health. I truly believe in that. So all the empowered women on this forum should start actually empowering the poor women. That's the
right. Yeah.
So in total, we have around 130 attendants. It is Mita included in the YouTube. Thank you.
Before we close, they say that every webinar should have a photo session. I forgot to do that in the beginning. So let's start. Have a photo session. Everybody who can turn on their camera, please turn on your camera, and we can have a photo session with the speakers.
There is interesting comment from Theo. Is there any man empowerment he mentioned?
Man empowerment is also needed.
But Lely, maybe you can take the picture. Thank you so much.
Lely, would you please take the picture? Yeah, we have
Okay.
100.
One.
Yeah, okay. 1, 2, and 3.
Okay, ready. Please wait. One, two. Done.
Okay.
Okay. Thank you very much. And thank you, Tesfaye, Tismita, Theo again, and thank you for everyone who attend this meeting. I'm going to close today's meeting with that one main theme. So let's empower women and also men. And thank you for your coming today, and have a wonderful day today. Thank you very much, everyone.
Thank you very much, Tess.
Thank you. Thank you.
Yeah.
Cheers.
Thank you.
Bye.
Thank you so
Later.
much. Bye. Thank you, Mbak Fitri.
Thank you.
Thank you, Mbak Putri,
Thank
and
you,
everybody.
Thank you,
Thank you,
everyone.
everybody.